All right. Chapter 4, health promotion and wellness for the client and you as the practitioner. Hey, work. All right. So let's skip to. So the one thing I want to tell you guys about these slides, when you're going through them and you're reviewing the PowerPoint, you'll hear it refer to Healthy People 2020 a lot. It's a government website. It's actually now Healthy People 2030. They updated it for the decade. Okay, so when you see Healthy People 2020, it's Healthy People 2030. Got me? All right, so let's talk about what that is. These are kind of their goals. Okay, can you guys see that, or is it too small? Okay. Their vision is a society in which all people can achieve their full potential for health and well-being across the lifespan. Okay, it breaks it down into different objectives and indicators and stuff. You guys can look at that later, but I want to talk about why does occupational therapy fit into just that vision statement. So a society in which all people can achieve their full potential for health and well-being across the lifespan. How does OT come into that vision statement? Okay. Okay. You work throughout the lifespan, right? And you've seen from literally from birth until death, we're there, right? In some form, occupational therapy is there. I think that, just in the statement, you can tie OT in with the aspect of potential, using what they can do to get the most amount of work done or find the potential that they have in them. I think that occupational therapy, a lot of times it gets underrated. People don't think about community programs and things that we do. You heard me talking in that video a second ago about men's cooking groups that they ran at that hospice care. People don't think about OT in that aspect. They think about OT doing range of motion on a shoulder in an outpatient clinic or teaching somebody how to dress or bathe. They don't think about community groups that are led by OTs. And that very well could be a group they're not billing insurance for. It's just a group that an OT created, for data, or just because they wanted to create a community group, or they got a grant to do the community group, or whichever. There's a lot of aspects of occupational therapy that people don't think about. All right, so quality of life. We've talked about that a couple times. Trying to figure out what is important to these people. What is their quality of life? If you've had somebody that was a athletic trainer who ran 10 miles a day, and you had somebody who was kind of lived a sedentary lifestyle, didn't do a whole lot, and they both come into a long-term care facility, who do you think is going to have a poorer quality of life in a long-term care facility? Who's going to have that poor quality of life or poor feeling that they are? The athletic trainer, right? Because it's so different from what their life was before. So when you're concerned about someone's quality of life, it depends on what their life looked like. What were they doing beforehand, that prior level of function? Were they doing all the chores in their house? Were they cooking every meal? Were they doing the laundry for themselves, or did they not? This is all aspects that are going to make up, how healthy a person is and what their quality of life is. What do you think is the role of social participation in quality of life? Are humans social people? Even the most introverted people, are they social people? In general, in some aspect, yes. Even introverted people will come in and have a Facebook page or something. In general, humans make up a big part of our quality of life as being social people, interacting with other people. It's a huge part of it. And if you take that out of it, if there's somebody who they got their social participation from going to church every Sunday, think about the quality of life that a lot of people had that did that every Sunday, and then they closed down churches with COVID. My grandma she never misses church ever on Sundays. And then, now something comes around and they can't go to church. That's huge for her. That's her friends. That's her group of people that she can't see anymore. She doesn't have a Facebook. All she has is her phone now that she can talk to these people. There's no face-to-face interaction. And then on top of that, your social group goes into your family too. They couldn't see their families for long periods of time. Now let's take it a step further. I take somebody to a long-term care facility who rarely got to see their family anyway, or might even be confused the reason that they're there. And now they're locked, more, for lack of a better word, locked in a room. They have no social participation other than the person coming in their room dressed in full PPE. Think about the social impact and the quality of life impact that COVID had on people, right? And then it makes me sometimes feel like, my social participation was a whole lot higher than, someone like my grandma or someone long-term care facility was during that time of COVID. You couldn't see anybody, couldn't do anything. And I was like, man, this sucks. And I really thought about them like, wow, that really sucks. The little bit of social participation they actually had taken away. So there's already studies coming out on like rates of depression in nursing homes and how skyrocketed it went, and for elderly people and their quality of life studies and stuff, all of it's trended downward big time over the last couple of years. Pretty sad. That's just a little side note. But other than, your friend groups and stuff, what are some other ideas of social participation? Think about things you do that makes you a social person. What are some things that you guys do that increases your quality of life? If you can't think of something, say, if I couldn't do this, it would decrease my quality of life. What is something that if you couldn't do it, your quality of life would decrease? All right, we're going to go around the room. You really like to go out and eat? Yeah, and we couldn't do that, right? Even when the governor was like, go to Bob Evans, you want to go to Bob Evans, go to Bob Evans, yeah, that's a big, if you couldn't do that, okay, think about something that happened with God forbid something happened, you had a disability or an injury or something. Now you're not able to go and do that thing that you like. Can't go out and eat with your friends or your family or whichever. You can't do that now. That's a big quality of life thing taken away from you, right? Or some other things. Jennifer? No, what something you do? Yeah. Your quality of life. What helps make up your quality of life?
I guess just going to work. Like
Yeah. You didn't get to see Lindsay every day. Had to work from home. Sucks, right? Some people actually enjoy going to work and seeing their coworkers and stuff. I love this job. I like coming and seeing you guys and my coworkers. We all get along really well. So if I couldn't do this, I would be kind of at a loss of what to do. Work is a huge one. What else, Lindsay?
Just going to a store and walking around.
Okay, just shopping.
Yeah.
In general, you like to shop,
Mm-hmm.
and now you can't do that. Your quality of life will probably go down quite a bit, right?
Mm-hmm.
Yeah. Isaiah?
Being outdoors.
Being outdoors. Okay, so if something happens, you couldn't go hiking, or it's huge in the Fayetteville region. That was about the only thing I swear that didn't shut down with COVID is you were still allowed to go on a hike. You could do that. So those kind of people, didn't go too bad. But okay, what's yours? Traveling. Couldn't travel. I love to travel so much. Very rarely am I home on a weekend. I normally am out doing something or going somewhere. If you couldn't travel, couldn't go nowhere. A lot of people couldn't. Quality of life sucked. A lot of that stuff come into perspective with COVID though, because most of these things we're talking about were taken away. What do you got?
It's just like friends and I always get together and go somewhere, do something.
Yeah.
Socially, like go to wineries or.
Right, for sure. I think it was weird too, like how cautious everyone was around their friend groups they've been around for years, and like am I supposed to go there? Like, are we allowed to play cards tonight? Like, is that going to be accepted? I think it's weird. But something like that being taken away, it's a huge thing. You feel like you missed out on something. Your quality of life's undone. We got, huh? Oh my God, that was the hurt. That I hated not being able to go to concerts. It was. But even now, like I said, I went to that Luke Combs concert a couple weekends ago, and it still felt weird. Like, wow, there's this many people here. Like, I would have never thought about that stuff before. I would have just enjoyed the time. But it's that aspect of, is it safe? And I think even that impacts quality of life. Now you're unsure about those things. Like you guys said, like the WVU game, I've rarely missed a WVU home game. Like, it's kind of rare for me to not be at the game. But now you have that thought in the back of your head, like, you can't even enjoy it as much now. You can't even, do the things that you're used to. So think about this kind of stuff. Now put it in the aspect of somebody who's literally gone through something life-changing, like an injury or a stroke, whichever, and now all that is gone for them. Their quality of life has gone way, way, way down, right? But for somebody who, that example I gave a second ago, that they may have gone through something, gone to a long-term care facility, if that kind of matches how their life was anyway, like a sedentary lifestyle, not really want to do a whole lot, their quality of life didn't go down as much as what the other person. So they're going to have a little bit harder time, the more active person in that transition, right? That's kind of what we're going to talk about today. First, we got to define a couple things. You have health literacy, and these these definitions, I pulled them pretty much straight from your book. So I think this one's on page 59. So you guys can highlight and go through. But it's health literacy is the ability to obtain, process, and understand basic health information and services to make appropriate health decisions. Okay, so being able to pretty much make informed healthcare decisions, if you want to break it down. What are some signs that someone might have difficulty making those decisions? Okay, so there's actually an impairment there that they can't make the great decisions. Dementia, Alzheimer's, TBIs, things like that. Very good. What are some other things?
Like being uneducated.
They're just completely uneducated.
You go to the doctor,
Right.
the dentist.
Right. So just literally not knowing. Right. So another thing that would be a sign of it would be making poor healthcare decisions on the outside of it, like maybe taking more Advil than is prescribed, and just because they don't know any better, or that's really the only example popping in my head right now, but just making poor healthcare decisions overall. Not brushing their teeth. There's another one. Like, if they're just not brushing their teeth, they don't really know the benefit of it, or these are problems, and there might even be a disorder of some sort there, or an injury of some sort, that are assisting these people in not being able to make these decisions. So how can you distinguish between health literacy, visual problems, like that's the idea, don't ever think that's not being able to, see the directions and stuff, or know, and non-compliance. Non-compliance meaning that they know what is healthy and they choose not to do it, and they're able to make that decision. It's non-compliant. How do you think you can tell the difference between that? Somebody who lacks health literacy, visual problems, and non-compliance. Visual problems pretty much self-explanatory, but health literacy and non-compliance. So somebody that doesn't want to do it. How do you make that distinguish? We put it in a therapy aspect. You have a patient who needs therapy, and they don't want to participate. How do you know it's health literacy or non-compliance? That's an interesting point. What do you mean know them better? Right, they can absolutely manipulate you. Are they the question here being, that you need to answer is, are they choosing not to work with you simply because they don't want to, and they're being lazy, or have they actually done research and they don't agree with the treatment method that you're using, or they don't think it's a benefit, or something like that? Or is it they're just outright refusing with you? Maybe. Non-compliance is huge with patients. You'll be saying, you know, here's the home exercise program that you need in order to gain strength, but they don't do it. That's huge. People, if you know, especially in home health, you get 2 or 3 days maybe with them a week, and you're there for 30 or 45 minutes. The rest of the time, what are they doing? Are they sitting in their wheelchair or sitting in their recliner and letting somebody else take care of them? The only exercise they're getting is walking to the bathroom and to their bedroom, and that's it. Like, there's not a lot of benefit that you can do. It can be very, very frustrating when you know exactly how to help a patient, but they won't let you. Talk about making you mad. Like, my gosh, you put a lot of effort into making sure your patients and your clients are treated well, and you've done your research, and you know, you've gone to school, come up with treatment interventions, all this other stuff, and then someone's like, I don't want to. Like, all this effort you put into it, you know, and the patient tells you no, that can be really hard to deal with. So how can we address if someone is lacking health literacy? There's a few methods here. You have what's called the teach-back method. These are really, really big, and I want you guys to know these for practical scenarios and exams and when you go out practice. These are really important. You have the teach-back method. This is where the client just repeats back to you or teaches you how to do it. Teaches you. So let's put this in an example. You taught them how to put on a shirt in a different type of way, okay? Instead of them saying, oh, yeah, I got it, you actually have them show you and walk you through how to do it. That way you know exactly, or they know exactly how it's supposed to be done. And it provides a lot of opportunity for you to get feedback, like, no, let's try it a different way. Okay, now show me. The Ask 3 method is really big, too. That's where you just tell a patient, listen, at every treatment session, I want you to ask me at least 3 questions. That opens up an environment where they can ask questions, and it's an open line of communication. It's extremely, extremely effective. Next is just creating a shame-free environment. Making sure that you do have that open line of communication. They're able to ask whatever they want, and know they're not going to get made fun of, that every question is serious. Supplement text with pictures. I do that I normally don't give any home exercise programs that are just handwritten. I always give them a picture or a handout of some sort. I don't like handwritten ones. I don't think people understand or learn how to do it. Like my home exercise programs I give to patients will say, here's this exercise, do it in this way. Here's a picture of it. Here's a description. And here's a little word to help you remember what it looks like. Like, you know, shoulder abduction, I'll have, you know, this move here looks like doing the disco. So I'll write on there, disco. And they're like, oh, yeah, I remember how that one's done. Next is tailor activities to the client's daily routine. If it's part of what they're doing already, they're more likely to do it. Next is easy to read text and diagrams. It's very simple. Don't put it in, you know, medical terms. Put it in layman terms so they know what they're reading. Last is clear, culturally sensitive language. Just making sure that it's, you know, they shouldn't have really any question on what you hand them. It should be very self-explanatory. Okay. Cool. Any questions? All right, we'll keep moving. Occupational injustice and risk factors. Go to page 61. So I'm pulling these from the book because I can't define them any better myself. So occupational injustice is defined as individuals, groups, or communities and nations experiencing a lack of meaningful occupation for its members in their daily lives. Again, this is on page 61. Occupational risk factors that are they affect someone's health and well-being. Okay. This is just defining some stuff for you, okay? When you see these, I want you to be able to know what they mean. Occupational deprivation. This is where someone is deprived or given a lack of choice because of things that are outside of their own control, that are beyond the control of the individual. This, again, I'm sorry I keep bringing up COVID. I just think it's so fresh in our minds. It's what comes. But this would be like COVID, that they took away things that was outside of our control. We lost the idea of choice. Next is occupational alienation. This is a sense of isolation, powerlessness, and loss of control. Next is occupational imbalance. This is a disproportion in work, play, and rest. This creates a loss of like who you are or your well-being, or stuff like that. If you're working way too much and you don't get any play, you've kind of lost who you are as a person. Or in the other aspect of that, if you're a hardworking person and that's what it's who you are. If all you're doing is play, you hear people all the time, they've worked for all this time and then they retire for a year, and like, I was so bored I couldn't stand it and I had to go back and work part-time or something. And last is occupational marginalization. This is where a person's occupation might be meaningful to other people, but not meaningful to the person. This might be something like, wow, you're doing something really, really great for the community. Wow, wow, wow. But if you're not passionate about it and it's not something you want to do, it's what really is the point into you. This again goes into that idea of choice. They probably didn't choose to do that. If they don't like to do it, they probably didn't choose to. Okay. Cool. Any questions on those? All right. Occupational resiliency. What does resiliency mean? It's great. Ability to adapt. What else? Someone is resilient. What does that mean?
I always say like,
Okay. Yeah, I think that's a great idea to think about. Stubborn or not wanting to give up or something. Okay, what else? Great, motivated. Any other ones? Your book defines it a little bit different. It says it's being able to endure stressful situations and not suffer physical or mental consequences. No, not really. There's not going to be a question of what's the definition. Just know what resiliency means in a well-rounded about way. All right. So let's talk about some different strategies to help someone stay resilient. Being able to take in stressful situations and stay resilient against those situations. Let me go to page. Okay, risk focused. This is where you're going to identify risk factors and address them before they even happen. An example of this would be like parent skills training. Like, listen, the twos are awful. Here's something that I did that will help with this. If your child starts to draw on the walls, this is what I did to stop my child from drawing on the walls, those kind of things. Asset focused is increasing available resources so that people have what they need to appropriately respond to those threats. Asset is all about resources. This is like a woman's shelter or something like that. Giving them resources to help get on their feet and be more resilient. Okay, process. This is increasing through, like moving them through the system, like self-esteem building up. Like, listen, this happens, moving it through. We're just going through the process. Okay. Every one of these leads to, occupational resiliency. All right, now, without looking at your book on page 63, this is defined in your book, but why is resiliency, why is that a precursor to adapting? Don't ever think that. Why does someone need to be resilient in order to be adaptable? Okay. Okay. What else? Okay. Yeah, I think that's good. You need the motivation. You're right. Adaptation is like half of what we do in occupational therapy, right? We're helping people adapt to these new circumstances and situations. If someone doesn't have that resiliency, find out what's important to them, finding that motivating factor, or why would they want to adapt? Why are they going to see the need for adaptation? That kind of thing. Then you have the idea of internal adaptation and external. Let me back up a second. Why, if someone has a higher level of resiliency, do you think those people are going to have better or worse outcomes? Why? Why does someone that's more resilient have better outcomes? More willing to try. Okay. What else? What was the word you told me a second ago? Motivated. They probably have that more of a motivation to get better, right? Sometimes people don't have that idea of motivation. They don't know why would they even want to get better? Why do they want to get stronger? Why do they want to be more independent? I mean, sometimes, and a lot of times you'll get people, it's like that is their motivation. They just want to be more independent. Some people have to be coached into that. Like, listen, this is what you can have so much better quality of life. This is why. What did you do before? Okay, we want to get you back to that. This is how we do it. Those kind of things. An internal adaptation is changing their mind, changing what is going on inside of them. External, be changing the circumstance or changing the resource or whichever. Changing the environment. Okay. Now, before I go into the next slide, I want to read a definition from your book. It's on page 63. It's about health promotion. Okay. Health promotion is a process of enabling people to increase control over and to improve their health. Helping people increase control over their health and improve it. Okay. What role does occupational therapy play in that? What do you do to help someone take control over or increase their control over their health and improve it? Educating them. Okay. Meredith, what else? Well, you're not improving their health necessarily, but how do you, health promotion is helping them gain control over their health. So how do you help them do that? Okay, education again. Allie, what might else we do?
Educating them, but showing them.
Okay. Okay. What's thing that I told you guys several times now about resources? And knowing your resources, being able to say, hey, there is this program or there is this doctor or whoever who can help with this situation. A lot of people just don't even know that there's something out there to help them. It's our job to know that, or at least know the person that will know it, which a lot of times is the social worker. They know a lot. That's kind of what they do, is especially in long-term care and as far as therapy is concerned, is knowing different resources and stuff like that, helping them get signed up for different types of insurance or whichever, what might be more beneficial for the client. Very good. Some other things that we're going to do: decrease effects. Here's some examples: decreasing effects of cancer treatment on daily functioning. So, helping them find out a way to continue to do their ADLs and IDLs even while during cancer treatment. Health risk assessments, doing these questionnaires or these healthy lifestyles. Are you a smoker? Oh gosh, here's what that can lead to. Next, client education, big one, right? We already talked about that one. Environmental modifications, changing everything about their environment or something small about their environment. Putting them in a rehab facility where there's a gym for them to use the equipment and be with a therapist and working, trying to gain strength, rather than them being at home and alone. That's a total different environment, right? That's promoting health of itself. Last is skill training, teaching them something new. Like that men's cooking group a second ago, those kind of skills, or even like a public speaking or community gardening group or whatever it be, those kind of things, learning those new senses of occupation. That's huge in OT. I mean, people will get grants for this kind of groups all the time at the state and federal level, and they'll be run by an occupational therapist or an occupational therapy practitioner, because we understand that more than anything. One area OT is trying to get in right now is prison systems, especially in West Virginia. Think about people who have lost a sense of occupation or are unaware of, maybe even put it on a lighter terms, or like the world outside of, prison. These kind of people need that sense of occupation and being well-being again, right? This is something we're actually working with at the Capitol now, is trying to get OTs grants to work in prison systems. So that's a big emerging practice area. One of the biggest goals in promoting health and wellness, or the biggest goal I want you to remember here, is grading the activity. Grading the activity, okay, meaning making it easier or making it harder. That's when I say grading, that's what I'm talking about. You make it easier or harder. And then adapting treatment as well. That could be, again, it's grading / adapting to make it more fitting for that person. Okay? We good? We're almost there. Here's some examples: is weight management and obesity prevention groups, promotion of physical activity, ergonomics and injury prevention, universal design, I want to talk about that one in just a second, and chronic disease self-management. These are all different types of groups and things that OTs can work in. Universal design. What that means is creating something or a piece of equipment or an environment that is good for everyone, regardless of the way that they are or a disability that they may have. For example, elevators is a universal design. You can use that if you're in a wheelchair, or you can use it if you are not in a wheelchair. Certain types of door handles, like this is a universal design door handle. If you have poor hand strength, you can still pull down on the handle with your elbow, or people do it with their feet, and put your foot up on there and push the doorknob down. It's a universal design. The important part of that is it's a design that's not different or outstanding to make it like this is a handicap. This is just everyone can use it, rather than saying this is the handicap entrance. This is just the entrance, and now everyone can use this entrance. Yeah. Those are cool. Universal design, a lot of them were done with occupational therapists on the teams that created these scenarios. So, all right, some psychosocial considerations. Adjusting to a disability is absolutely huge, right? Something brand new. You go through 4 different phases. It is vigilance. This is where the person attempts to cope with the trauma. This is first phase. Next is disruption. This is the loss of control. My notes.
Not in here.
I don't know. Probably.
This phase one is that what you just said?
Vigilance. I don't know where I'm at in the book here. Nope, it's listed under 69 adjusting disability. On page 69. Earliest page is vigilance there, 4th sentence down. All right, so vigilant. Disruption and during the self. This is the third phase. This is your awareness of the surroundings and kind of coming. I like to think of this phase as like coming to terms. Now, like understanding what goes along with the disability a little bit later. Then last is striving to regain the self. This is trying to get back to normal after the disability or injury or trauma or whichever. On page 70 and 71, there's a couple factors like faith, acceptance, and personal responsibility that throw those for a loop. I'll let you guys kind of read about those, but make sure you do. There are test questions about those on complicating factors. Besides it being a massive impact on the patient or the client, who else is it a massive impact on? A new disability or injury or trauma or family. Family is huge. That's a big area of family consulting and stuff. Sexuality concerns, that's another big part. You know, sex is being part of being a human. You know, sex is part of it. A lot of people don't understand or know that occupational therapists work with sex and all that stuff. And as uncomfortable as it may be, you know, it is part of a human aspect of life. And we work with that, especially if the client has concerns on it. Thinking outside of the aspect of a disability on how that can affect, you know, that aspect of their life. And then lastly, I want to talk about their spirituality too, is like, are they able to find meaning and purpose? You know, if the patient, if that's what helps them get better, that's what helps them get better. Don't, you know, if someone feels like spirituality or being religious or whichever aspect you want to talk about, and if that helps them and helps you gain their goals, work with it. You're not there as a judging person in any aspect. You're there to help them get back to their former level of function, right? Or find a new level of function. Cool. Yes.
Did we watch that video in this class?
Which one?
Okay, I don't
Okay. All right. The basics of being wellness for you guys, for the practitioner, some things that will help, you know, you practice long, successful careers is getting restful sleep, adequate physical activity, good nutrition, social support. The one that's not on here that is really big is body mechanics, using proper body mechanics, transferring somebody the right way. That's going to help keep you in the career as long as you can. So how is that stuff going to help? It's going to be injury and illness prevention, stress management, prevention of compassion fatigue. We'll talk about that one in just a minute. All that stuff's going to help go into making you and make your career a much more happy place. Okay? Your overall health will be better. All right, compassion fatigue versus satisfaction. Why? Well, first let me define it for you. Compassion fatigue is, in a lot of areas, people think of it as burnout. Okay, so you're passionate about something, but now you just got to the point where like, I don't want to do it anymore. I'm done. It's so taxing on me. I'm done. How can you help prevent some of those things? Page 74 and 75. Okay. Burnout itself is where the job has become so stressful, or you've just kind of got tired of it. You know, I don't want to do it anymore. That's pretty common in therapists because we are so empathetic towards people and trying to set those boundaries between work and personal life. And especially if you do that and then do community work outside, it's hard. It's easy to get burnt out. I've been burnt out several times where I'll be doing, my full-time position, then go do PRN and all the driving and stuff that I do. It's easy to get burnt out. It really is. So you have to be very careful of that. The next one is vicarious trauma. This is where you become so empathetic that you are taking in stress from other people. So they've gone through something and they have their own stress on their life, and you listen to their stories and you empathize with them so much that now you've become stressed. This all ties into compassion fatigue. And then secondary traumatic stress. This is the aspect of not just taking on their stress, but now you want to help. Like you feel like it's your situation. Like you need to do something about it. One thing you got to learn right now is you're not going to be able to help everybody, no matter how much you want to try. There are going to be people that no matter how much effort you give, they're either not going to work with you, they're not going to get better. There are situations like that. So, I was really bad for that when I first started out too. I wanted to fix everybody. I was OTA of the year, wanted to do it. Like I was all about it, but it's easy to get burnt out. One more little figure and then we are done for the day. Go to page 76. You see that little figure down the bottom left-hand corner? It says this is a good way to help reduce your risk of compassion fatigue. Avoid stress, increase relaxation. With removing yourself from the work setting equals decreased risk. Not rocket science, but still really hard to do, right? When you're passionate about it and you want to help people, which is the only reason most of you come into occupational therapy, right? You want to help people, you want to do something good. It's really hard to set those boundaries, but you have to, or you will get burnt out. It happens to everybody. Okay. Any questions? Are we good? All right. You guys have 2 knowledge assessment questions for this chapter as well. So you have a total of 4. You turn them in separately. Okay. Put them on separate Word documents. For this one, people may experience 4 phases in adjusted disability. Put them in the correct order. Very self-explanatory. Next one is, which of the following is a health promoting attribute? This one's also pretty self-explanatory. Okay. Any questions? Nope. No. And normally, yes, but for this, no, because I've given you 2 chapters to review. Okay. All right.